Hi, this is Brian Kim. I'm going to share with you case number 49 in the best way to do cataract surgery series. This is a soft lens and a sticky lens, but the reason I'm posting this is because the patient has a sudden jerking head movement. He actually jerks away from me, and so I'm going to show you how I manage this. This patient has been optimized with anesthesia. I don't like to snow the patient. I don't like to give them so much anesthesia that they're sleeping during the case because that can cause other problems. And so I prefer the patient to be awake, being alert, and try to be responsive and cooperative with what I'm doing. But in this case, this patient was really having these involuntary jerks, and I'll show you how I managed it. And so I'm using a cotton tip to hold the eye central, and then I'm using a corneal marker to help me and center it. Oh, and you can see that sudden jerk away from me. The patient had that head jerk movement, so now I'm aware, and I'll be thinking about it throughout the entire case. I'm making a stab incision on the right side, which is this is a right eye, so this is stab incision on the right side, and then on the left side, making sure I'm flat to the iris plane to make a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some intracameral dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. I want to make my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter, and that's a triplanar corneal incision. Oh, there's that other jerk movement right before I put my capsular rhexis forceps in. And so I'll go ahead and do my puncture technique. I'm puncturing, pulling down, and then grabbing on the right side, I'm going around. You can see I'm going a little bit faster than I normally do, and it's because of this head jerking movement. And this is really the most critical step where I can't really afford a bad head jerk, which is going to potentially compromise the surgery. And so I did that fairly quickly, hoping it was going to be fairly well centered and sized. This is the capsular fornix hydrodissection technique. I place the cannula out underneath the anterior capsular edge contra-incisionally. I point the tip down, get a nice fluid wave, decompress on the left side, turn it to the right side, you get a nice spinning lens. I'm irrigating the surface of the cornea and then lifting the incision with the chopper, removing the surface epinuclear material, placing the chopper underneath the anterior capsule out to the capsular equator contra-incisionally, turning the phaco-tip vertically, sub-incisionally, crushing the lens piece. That's a double chop maneuver. I place the chopper out underneath the anterior capsule edge on the contralateral right heminucleus, pull it centrally against the phaco-tip, and this is the cross-chop maneuver bisecting the right heminucleus. I use some vacuum in the chopper to pull that first quadrant up, and then crushing the lens piece with mechanical fracturing forces. This is a fairly soft lens. I do the same thing for the second quadrant, pulling the piece up and crushing it with mechanical fracturing forces. I turn the second heminucleus in front of me, and the eye turns again, but thankfully I have both instruments in the eye by now. I place the chopper out to the equator, crushing the second heminucleus in half, pulling the third quadrant up out of the bag with the vacuum and emulsifying, and doing the same thing with the last quadrant. I'm using high vacuum to pull the epinucleus up. You can see this is a sticky lens. This has got a pretty thick epinucleus, and so I'm taking my time. It's not just prolapsing out of the eye. I'm using a little bit of aggressive vacuum, having to sandwich it and crushing it a little bit. And I'm really just using vacuum. I don't want to use any ultrastatic energy when I know that I can just suck it up. I'm left with some of this subincisional epinucleus. I'm trying to get underneath and around that lens piece. Finally, I do. I pull it up out of the bag, and I'm able to emulsify it. And so you could see how sticky it was. It was not going to come out just with the vacuum. And so using the chopper, turning it and rotating my wrist, getting underneath it and pulling it up, hooking it at the capsular equator, and then prolapsing it up. It was a lot easier to do it that way. I take the chopper out, push BSS in, take the phaco tip out, and then put the INA handpiece in, and I'm starting the cortical removal now. You can see the cortex is fairly loose, and now I have a bunch of wispy little material there. I'm using some foot modulation to carefully go around and polish underneath the anterior capsule edge into the capsular fornix. I don't want to use too high vacuum when I'm going deep in the bag, accidentally grabbing the anterior capsule. So I'm going to the polish mode now, polishing here first on the posterior capsule surface. There's some fine cortical material there. Again, I'm confident doing this technique with the polymer tip, and I'm not really making very aggressive side swipes. You're just being very gentle, because in weak zonules, you can't pull on the zonules when you do it too aggressively. I'm pushing BSS through the paracentesis into the subincisional capsular fornix. It was pretty clean there. Now I'm injecting some cohesive viscoelastic to fill the bag. I could see the eye was kind of jerking a little bit, so I put the sweep in the eye as well for extra control. I'm sweeping on the left side and then on the right side. You could see I'm hustling a little bit because I don't really trust this patient. And so this is a 3-piece lens, and I'm going to go ahead and widen the incision using this paracentesis blade. I'm injecting the 3-piece acrylic intraocular lens into the capsular bag. It goes in quite nicely. I turn the bevel facing to the left. The haptic goes out in a planar configuration. It's going into the bag, and then as the optic comes out, I turn the barrel counterclockwise about 90 degrees. I let the trailing haptic come out pointing to the right, and then I dial the trailing haptic using the Maltzman. So I'm going to go underneath the lens, removing all the viscoelastic from the bag, and then I'll hydrate my incisions. And so this is a patient who had sudden jerking movements. I think the point of the video is simply to say, sometimes it's not ideal, the patient's jerking their head. I don't really think blocking the patient would have done anything because he's literally moving his entire head. His head is taped, and so it's a little bit of a challenge in these situations. Of course, this patient probably has some level of restless leg or maybe sleep apnea or some other factor that's causing him to have the head jerking. And I think in the very beginning of the case, when you're really doing the surgery with one hand, this is the most critical time, because with only one hand in the eye, you don't have as nearly much control. Once you have 2 instruments in the eye, it's really kind of a much safer situation. You could hold the eye with forceps, but I do worry about torquing the eye and causing corneal stria or causing viscoelastic to egress during any of these maneuvers. And so really the key is being aware of the direction in which the patient moves the head, anticipating that can happen throughout the case, being mindful of that at each step, also talking to the patient, letting him know the most critical parts of the step. I feel like talking is really the biggest thing that I do during these cases to help calm the patient and direct them as we get through the case. So I hope this was helpful to you, and I thank you for your attention.